I'm Nikhil Mull, co-director of the Penn Medicine Center for Evidence-Based Practice.
And I'm Ilona Lorincz, Director of Quality for Endocrine.
And in our roles, we lead bringing evidence-based practice to Penn Medicine. We at Penn Medicine strive to deliver evidence-based, high-quality care in a consistent way. When we started out our project, we thought we just needed to figure out how to disseminate the evidence-based guidelines we'd gathered over months, a build it and they will come mantra. In the old paradigm, groups would spend months or years putting together policies, protocols, and guidelines. Education was provided and the guideline was posted, and then we'd educate a few months later after realizing the guideline wasn't as efficacious as we'd hoped. Traditionally, that's where we'd be done, but that's where this team just started, moving out of the office and onto the wards. With 133 pathways and dozens more in the pipeline, we wanted to learn quickly and we wanted to know what actually worked, how to translate best practices into action at the bedside. Management of diabetic ketoacidosis was our first case study to inform implementation of other pathways and is quite a unique challenge.
DKA is the most severe complication of type 1 diabetes, and the high blood sugars are life-threatening if left untreated. There are approximately 200 to 300 cases of admissions for DKA per year at HUP alone. Let's follow a patient with DKA through their hospital stay before we started. There are no systems in place to identify these patients in real time, and the presentation is variable. There was a lack of consensus about appropriate treatment. We identified at least 7 guidelines in use for DKA. The conventions recommended that all DKA patients be treated in the intensive care unit. However, studies have shown that DKA can be effectively and safely managed with half the amount of monitoring. We challenged ourselves with streamlining this care. We wanted to ask ourselves 3 things. How can we identify the right patients and avoid under and over treatment? How can we translate one evidence-based guideline into action? And how do we set up the appropriately resourced location to treat DKA? Who are the right patients? The criteria for DKA are complex, and it was challenging to identify patients retrospectively. We needed to follow them prospectively. So we developed a real-time agent dashboard together with the center to help us do that. After following a cohort of patients using the pathway, using the dashboard, we quickly learned that the prior policies had been misdirecting providers and were leading to overtreatment. We had not been using the evidence-based definition of DKA in the most commonly used DKA pathway at HUP. In 1 month of 21 patients, 1 of the real DKA patients was missed, and 4 patients without DKA were overtreated, leading to unnecessary delays in interventions, potentially MICU admissions. We adapted new specific criteria, now in use at HUP for the past 5 months, and narrowed the patients eligible for the pathway without missing any high-risk patients. Within the first few weeks, we learned from our ED providers that education had not reached many of the medicine providers, so we began to embed ourselves in the process and actually joined the curator text messaging threads. Even at 11 p.m. at night, we watched how bed decisions were made. First, we joined the thread so we could understand in real time what was happening, and then we helped to triage. Our materials were also proving to be a barrier to effectively implementing the pathway. We'd created a resource on Dorsada with a quickly drafted paper version. We heard the content was great, but it just wasn't usable. So we started from scratch with a paper prototype and adapted it multiple times to best fit how people were actually using the tool. When these pathways were used, we saw that providers were nervous about causing low blood sugars and wanted to stop following the pathway and stop giving insulin. Having such formulaic rules, if this, then that, made people want to abandon the pathway entirely. So we helped them out with key principles to help people be more confident in the pathway and to allow for deviation when necessary. In their busy workdays, people just simply forgot where the pathways were located. So we started pushing it to them when a patient was eligible. Even when they knew about the pathway and could still use it, we found that some providers didn't want to start the pathway because it prescribed the MICU. The MICU was a solution that had a lot of the things that were necessary, but also way more than was needed. The convention was DKA equals MICU, despite the evidence. So we needed to figure out who still believed that and why. When we presented the ED providers a decoy non-ICU option, 100% of ED providers chose it, and they wanted to tell their colleagues about it right away. bed managers, we figured out, already triaged these patients away from the MICU and put them in a holding pattern until they were off the protocol and could be sent to the floor. But some floor nurses and physicians had hesitations, and it came down to perceptions of acuity and the number of interventions required by these patients. So without a consensus, we needed to convince providers that it was really possible to do this at Penn. To do that, we needed to create a separate space. We opened a targeted intervention unit where we could pull in the resources that we needed. So as patients, the first few patients came into the hospital, we set out to triage them in real time, to enroll them in a pilot to treat them in this unit. The unit was staffed with floor nurses, on-call ICU nurses, and a range of other resources providers thought that they might require. And with the first case, we learned so much. We did not need the MICU, and we could free up MICU beds for other sicker patients. The ICU nurse was not needed, and a huddle at the time of transfer with the pharmacist was more important. Our providers were also using our worksheets to hand off as a communication tool. By admitting patients to the targeted intervention unit, the ER length of stay was shorter compared to the median floor patient, and we saved the day that patients used to spend in the ICU. As we continue to enroll patients in this pilot, we anticipate eventually diverting 100% of the patients who used to go to the MICU with uncomplicated DKA to the medicine floors. We've improved buy-in from being able to demonstrate a new standard case by case at our own hospital. With this work, we are truly promoting people to work at the top of their license.
Remember our old system, serpentine and full of pitfalls. In 90 days, what we discovered was what it takes to implement pathways. It involves not just figuring out how to disseminate evidence-based guidelines, but also making them actionable in context and in real time to get it right. We can identify the right patients and avoid overtreatment with new specific criteria. We can translate guidelines into action using the right format while channeling it to the right providers. We iterated with paper prototypes and learned where less is more. We can set up the appropriate setting to safely test treatment of DKA at a lower cost and resourced appropriately in a targeted intervention unit. We plan in the next 90 days to implement this for all DKA patients over a larger scale to really see the impact on length of stay. And we will begin to automate pieces of what we've done, enrolling patients to optimize our current decision support tool and incorporate it into the Penn chart workflow to streamline the process even further. What we've learned is that implementing pathways involves a co-creation process in context to get it right, and that knowing what really is right, what the right thing to do, requires challenging conventions along the way. We will carry these insights to other pathways beyond just TKA. We're really just getting our own path started now.